Hello, my name is Paul Riley from the scientific marketing team at Diagnostic Estago, and I'd like to introduce our Lab Week speaker who is really kicking off our recognition of Medical Laboratory Professionals Week here 2024. So we have Dr. Sean Campbell, who is an assistant professor in the Department of Pathology at the Albert Einstein College of Medicine and director of the Clinical Chemistry and Immunology Laboratories at Montefiore Medical Center in the Bronx. His areas of interest include hemoglobinopathy diagnosis, monitoring and treatment, coagulation and hematology testing, along with multi-system standardization strategies. He's a really excellent presenter. I've seen him present several times for AACC or ADLM events, and we're really looking forward to his presentation today. Please take the lead here, Dr. Campbell, and we'll go ahead.
Awesome. Thank you very much for that very kind introduction, Paul. It's great to be here. So yes, I am the director of the chemistry laboratories here at Montefiore. But also, just so you know, I actually started my work at Montefiore as an assistant director of hematology as well. So that's where a lot of this comes from. But I've managed to keep myself sharp, as Paul said, by giving presentations on this as well. So I hope that this will be helpful to everyone. And this is aimed at providers, especially providers who don't necessarily specialize in coagulation, right? And so this is to help navigate things that at first blush may seem complicated, but in my opinion, it's not that bad at all. Okay, so we'll jump right in. Just very briefly, just so you know, my disclosures, most of these are not related, but I do have grant and salary support from CBA and Pfizer, as well as some travel support from Biography and Stago Diagnostic for this talk. But moving right along. So just so you know what we're going to get into, we're going to talk about the coagulation cascade with just the basics. Don't be scared. You know, a lot of people tune out when they hear about the coagulation cascade, but I'm going to make it very simple for you to know going forward. And then we're going to talk a lot about sample collection and common interferences. Because a lot of what I'm hoping to do is equip you for knowing what's going to be helpful for your patients and what the lab also needs to know about your patients to make sure that the testing that you get can be as accurate as possible. So we're going to spend some time on that. And then I'm going to also talk about the coagulation test use, and especially clinical tools that can be helpful for you both in interpretation of tests as well as to order the tests. And so they can really help guide you. So we're going to be the first half really on the lab side, on the sample sides, and the second half a lot on kind of this clinical interpretation and understanding of tests. Okay, so to jump right in, with our coagulation cascade, this is a picture probably many of you are familiar with, even if you don't have it memorized. I do not have it memorized, I'll say right up, even in my work. So a lot of what I'm going to tell you right now is how you don't need to memorize this to still be very effective in the coagulation space, right? So one of the first things to know is just to break down this. There's three major areas, right? They're all color-coded in this image. So you have on the right is your PT. You notice your PT is very small. It's a very small pathway. And really the one factor you have to know for PT is factor 7. It's really the only factor that's important for your PT, or specific for your PT. So it's just one. Then you have your common, and this is what's going to be activated in both PT and PTT testing. And even here, there's a few more for sure, but especially the main coagulation factors that you're going to be concerned about are 10 and 5. And that's actually basically where I'm going to stop. These are your three major ones, right? You need to know that for PT, you need your 7, and for common, so for both of them, you have 10 and 5. And everything else can go in PTT. And that's what I mean as far as, unless you're really digging into the coag space, you don't necessarily have to know that 8 comes after 12, or that 11 comes after 12, or that, right? That is helpful to know if you're really digging into a coag condition, but if you're just looking at PT and PTT results, really trying to figure out what your patient's happening for those, Really, 7, 5, and 10 are going to get you a lot of the way there already. And then you can always look up your coag cascade for the rest of them if you need to be more specific. And that's it. I mean, we've simplified the coag pathway, right? And this is really, this is not unusual, right? I don't know, even though I'm in chemistry, I couldn't tell you offhand the entirety of the Krebs cycle. That's not the, the important thing. For treatment of our patients, we don't need to know just off the top of your head for every situation the entirety of the pathway. You just have to know the generalities. So I hope that's helpful. All right. So that's our coag pathway. That's what we're measuring in PT and PTT. So let's talk about how the actual tests work. Sorry, there you go. Okay, let's talk about how these tests work. And I have to shout out Dr. Ayala Lopez for inspiration on these images. She's a whiz with PowerPoint. But all right, so when you come to the lab, we don't tend to use test tubes anymore, at least not for our tests. But we can all imagine we have a test tube. And to this tube, we're going to be adding first your patient's citrated plasma. And this citrate is going to be very important. We'll talk about it in more detail. But citrate is most important because it binds calcium. And I'll show you where calcium comes in. So you add that plasma. It's just sitting there. No clotting is happening. This is anticoagulated blood, so it's just sitting there. Then to that we add an activator, which may vary, and we'll talk about what those are, to the plasma. And again, just let it sit there. No coagulation is happening. It's getting ready to coagulate, but no coagulation is happening yet. And then we add your calcium. Calcium interacts with the citrate and restarts the coagulation cascade. So once that's our starting gun for the race, and then we just time how long the coagulation cascade takes to run. And then that will end up generating fibrin in the tube. This fibrin plug can be measured various different ways. Depends on the instrument. Sometimes it's optical, sometimes mechanical, but it all comes down to this fibrin being generated at the end. So if we go back to our coag cascade very briefly, we can step through that. So here we can see we can highlight calcium. Calcium is very important for both of the pathways. And that's where that citrate comes in. So as soon as you bind up that calcium, coagulation stops. You really can do nothing. There's also, I didn't even highlight, a third place that calcium comes in here in the common pathway. So it halts everything. And that's how we can have, basically put a pause on coagulation. Then we add our activators, and this is where you get the differentiation between PT and PTT. This depends on what you use to activate it. Again, these are specific with manufacturer and things like that, so we won't talk too much about that, but that's where those comes in. Now, when you have both of these, you have an activator, you have your calcium all ready to go. That is then going to proceed down, and everything is going to create fibrin, assuming things are working correctly. And so again, we don't need to know the specifics of 12 and 11 and 9 and everything to know how this is going to proceed. And this brings up a lot of different places where things may go wrong, which is we're going to talk about, so that we can help avoid problems in the sample and make sure that you get the best coag results that you possibly can. So again, basics are always going to be the same. You have your citrated plasma. You have citrate binding your calcium. You add an activator of some kind, then you add in calcium, and you watch to see how it proceeds. So let's talk about that sample. Let's talk about citrated plasma. So for sample collection, pretty much across the board, most of you probably already know this, but across the board, you're going to be dealing with citrated tubes, which are typically blue tops. So as this blurry image shows. Not necessarily 100%, but many coag samples, at least across the US, are going to have a blue top, typically a light blue top. So they're very easy to see. And you really can only use citrate tubes because, as I mentioned earlier, citrate helps bind up the calcium. Other anticoagulants I'll talk about may bind it, but it's just not as specific. It's not as clear as what citrate can do. So you really need citrate to be able to have your coag testing work. And specifically because so we can reverse that anticoagulation, right? If you have anticoagulated blood, it's not going to clot by definition. So we need to reverse that with calcium. Other anticoagulants do not work the same way. And so it's going to cause problems with our assays if you don't have citrate. Speaking of other tubes, I just want to say, just to make sure it's clear, never spot blood between venipuncture tubes. And this is true not just in coag, but coag is particularly sensitive, but across the lab, you never want to be swapping blood between venipuncture tubes, drawing it in one color and pouring it into another. So it can cause very large unpredictable errors because we don't know what's in the sample anymore. And so just in general, stay away from that. But moving on from that, I'm sure none of you ever do that. EDTA and heparin. So these again are anticoagulants. They can also bind calcium, and heparin has some other effects, but we can't reverse it in the same way that we can do it with citrate. And so that can cause major issues when we're trying to restart that coagulation in the tube. And these can be found, outside of other venipuncture tubes. A lot of IV lines and IV preps will have heparin or EDTA for that anticoagulation effect. You don't want it clotting in the line. So you really want to avoid, at all possible, drawing coagulation samples from either IV lines or even indwelling lines. We had an interesting situation actually just recently in our lab where this was in chemistry, but we were getting some weird results, and we found out that heparin was an interference. And this was from a dialysis clinic. So we're like, are you using heparin? Totally reasonably. And the doctor actually swore up and down this was before heparin was administered to these patients. They had indwelling catheters, but we did prove that their samples had heparin. So even if you don't think a line has heparin, you really want to avoid it for coag testing, because again, it can really throw things off and give you unpredictable results if you do that. So if all possible, avoid indwelling lines, avoid IV lines, and really try to avoid drawing from anywhere near an active drip. The general suggestion, right, is to use a separate limb if possible, to make sure to avoid that, because even again, if you're absolutely sure it's not there, it still might be there. So you just want to try to avoid that. And you want to make sure to fill these tubes to at least 90%. Many vacuum containers, many citrate vacuum containers specifically, will actually have a marking at 90% for this exact reason. And this gets back to the citrate. So when the citrate is at a very specific concentration in the tube, and we expect a certain concentration when we're reversing the anticoagulation. If you don't fill it enough, if you say have only 70% or 80%, the citrate in the patient's sample is actually going to be too high. And so there's too much there. And when we try to reverse the anticoagulation, it doesn't work, or it works very, very slowly. And again, you're going to get issues with the patient samples getting extended PTs and PTTs because we can't properly reverse the anticoagulation. So you always want to make sure that you're doing at least for 90. And again, as long as it's above 90, we're generally fine. So 90%, 95%, we're all right. But if you give a tube at 70 or 80%, that's really going to cause problems. And we're, of course, going to watch for that. And generally, we'll catch that before we give you erroneous results. But then it means you have to go back and draw even more blood from your patient, right? So we want to make sure that every tube we get, the citrate tube, is 90%. And this one especially doesn't apply to all testing, right? If you give a serum tube that's half full, that's fine. It's not going to cause a problem. But for citrate tubes, for coag testing, you really have to be sure that you're filling up those samples. Okay, so it's our sample collection. You got your samples 90%. You avoided your lines. Perfect, great. Everything's good. Of course, there can still be other interferences, right? So these are ones that we're going to talk about that you really want to make sure the lab is aware, because these could very easily be just in your patient, but can cause problems. But sorry, first the takeaways. Only use citrate tubes. Don't swap them out. Avoid your IV lines and make sure to fill to 90%. Okay, once you have all that. Of course, one of the major interferences that we can see is from other anticoagulants. A lot of the patients that you're measuring coag on have anticoagulants because they have thrombosis. And so these are going to be very important, again, to make sure that you're aware and the lab is aware of what your patient is on. One of the major ones, of course, is heparin. Both unfractionated and low molecular weight are anticoagulants, of course, and mostly are going to prolong your PTT, but can, especially in high concentrations, prolong the PT as well. So you want to be aware of that effect. And there are, of course, coag tests that measure heparin and low molecular weight heparin levels, which work just fine. They're calibrated for that. But if you're not expecting it, again, especially if it's, say, from a line, you can prolong your coag tests. You want to make sure that you and the lab know that a patient's on heparin. Similarly, EDTA, as already mentioned, binds many things, including calcium, and that leads to somewhat unpredictable behavior, which is why we can't use it for coag testing. Again, IV preps and lines may have EDTA, so you want to be very careful around those. Typically, you're going to be prolonging in both PT and PTT. Again, calcium is important all over the place, so if you have EDTA, it can cause problems in there. Next major one I haven't talked about yet are DOACs and NOACs. So these are direct or novel oral anticoagulants. They typically affect the common pathway. The ones I'm showing here are apixaban and argatroban, which affect factor 10 and thrombin respectively. And so those are going to affect both the PT and PTT, but again, these can actually have really unpredictable effects. They may prolong just a little, or they may prolong a lot. It depends highly on the dose, and there are more. There are at least 4 that I know of offhand, and I'm fairly certain there's more than that around. And so how these are going to affect your patient results is going to vary a lot. So these, again, you really want to make sure that the lab is aware when your patients are on these drugs. And again, much like heparin, there are coag tests that can actually help measure these in patients, so we can do that. But for just your general PT and PTT, as well as other more specialized coag testing, these can cause a lot of problems. There are things known as DOAC removal agents, which can do what they say, so actually take them out of your patient sample. So some labs, including at Montefiore, we have those. We can use those. But again, we have to know that they're in your patient before we're able to use them effectively. So you're seeing a theme here. You talk with your lab. They're going to have to, so you're going to have to let them know. And sometimes it's easy. Again, here we actually have, as part of ordering coag, questions as to whether or not your patients are on these drugs. So if those are available, make use of them because your lab is looking at them. But even if you don't have them, you want to make sure to communicate with your lab. The last one is a little bit miscategorized. This is a procoagulant, but is very important to know, and that is emicizumab, also known as Hemlibra, and it's a very powerful factor 8 replacement, and that's for hemophilia. So this is a very powerful hemophilia drug, and can lead to extremely short PTT results, which might make your patient look to be highly thrombotic. Hopefully they're not. And again, there are ways to avoid this and to get results even in the presence of emicizumab. But again, we have to know that is present in your patient. So really the takeaway of this slide is avoid your IV lines and let the lab know about the anticoagulants that your patients are on. Because once we know that they're there, we can potentially avoid them, get rid of them. There's ways to remove heparin and DOACs. There's ways to avoid the effect of emicizumab. EDTA is more of a problem, but at least if we know about it, we can potentially counteract it, or at least know that the results may be inaccurate. But so across the board, if you let us know, there's a lot that we can do to help make sure that you're still getting results that are helpful to you. All right, those are our anticoagulants and one procoagulant. There's also some general interferences. Again, I'm just going to come back, talk to your lab. These are instrument specific, which I'm going to go through, more than test specific. So these are ones that you really, really want to get in contact with your lab to see whether or not they're going to cause problems. The First one is bilirubin. Patients with jaundice may have problems with coagulation tests. This can be both prolongations and shortening, depending on the exact method that's used. And so again, you're going to want to ask your lab as to what, especially if you have a jaundice patient, of course, as to what effects it may have on the coagulation. And this can be very important, right? Because liver dysregulation can also cause problems with your coag tests, and truly messing with the generation of your factors. And so you want to make sure that you're figuring out which effect are you seeing. Is it the bilirubin, or is it the cause of the liver disease? So you want to make sure in those patients that you have accurate information. Similarly, lipemia, I have some oleic acid up here. It can cause issues, typically shortening, but again, this depends on your instrument, and the level of which it causes problems can also vary. So anytime, this is typically going to show up as high triglycerides, not exclusively, but typically. Again, the level at which that causes problems and the way in which that causes problems can be instrument specific. But these can definitely be a problem. So if you have a patient coming in with hyperlipidemia, it's always good to check with your lab to make sure what they're using and whether or not it's going to cause a problem. Similar to bilirubin, we have hemolysis. It can also cause prolongation or shortening, and again, this is going to cause interferences depending on the particular type of mechanism that's used in the coag test. So you're going to want to talk to your lab about hemolysis as well. Lastly, a bit more generally, but still good to talk with your lab about, are platelets. Platelets have huge reserves of factors, and they're going, that's what they do, is cause clots. And so if you have a lot of platelets, that can also cause problems, typically very, very short times, because these platelets get activated, they pump out huge amounts of factors, huge amounts of fibrinogen, and then you get a clot really, really fast. So most of the time in the lab, we are taking out the platelets. We have a lot of ways to make sure that that's happening, and we test to make sure that that's happening. So most of the time, these are not a problem, but especially if you have a very large amount of platelets, or if there's something potentially wrong with the platelets, these can cause issues for coag testing. So if you are concerned about that, if you think there's something wrong with the patient's platelets, or they just have a really, really high platelet number, it's good to check in with the lab and see how that might be affecting your coag results. But again, these are instrument specific, so you're going to want to chat with the lab. All right, okay, we're about halfway through. So again, as promised, we'll shift from kind of really looking heavily at the lab to talk really more on the clinical side and kind of clinical tools that can help guide you through use of coag testing. And those, we're going to be talking about DIC and 4T, as well as score and some more specific testing. All right. So to start with DIC testing, and this is really the one major one we're going to bring in a lot of coag tests up front, is in the diagnosis of DIC, or disseminated intravascular coagulation. And these particular criteria, there are a few, but this is one of the major ones that is put out by the International Society on Thrombosis and Hemostasis. This was published in 2007, and it's developed by this ISTH subcommittee on DIC, and is generally very well regarded. We'll just walk through each of these, hopefully give you firm grounding on how to use it. So for ISTH, again, we're going to use a lot of testing here, coag testing. So first of all, you're just going to look at your platelet count. DIC, again, disseminated intravascular coagulation. So this is coagulation that's kind of happening in a lot of places at once. And so your platelets are going to get activated, they're going to get removed from circulation. So you're going to see a drop in your platelet count if your patient is having DIC. So if it's between 50 and 100, it's moderate, you get a +1. But less than 50 is a much clearer sign that you may be having DIC, and so that gets you a +2. D-dimer, we're going to talk in a bit more detail later, but this is a very sensitive sign of thrombosis and clot generation. And this one, again, you're going to want to talk to your lab a little bit. So what's defined as a moderate or a severe increase, again, may depend on method, but generally, if it's just a little bit above your reference range, that's a moderate increase. And so it shows that thrombosis is occurring, but maybe not a ton. So you get a +2 for that. If it's severe, especially if it's multiples of your reference range, that'll be a severe increase, and that'll be +2. So that tells you that there's a lot of thrombosis going on, and so that's going to give you a +3. Your PT is going to be very sensitive to DIC, so we can use that. If it's prolonged just a little, 3 to 6 seconds. Again, it's showing that there is some sort of issue with the clotting factors, but it may not be specific, so you get a +1. If it's very prolonged, more than 6 seconds, above your reference range to be clear, you get a +2, as that's again saying that there's a lot of activity. There's something that's using up a lot of your clotting factors, and so that they're not around to be used in the assay. And lastly is your fibrinogen. So fibrinogen, I mentioned it earlier, that's what's going to be turned into fibrin to actually cause the clotting matrix. And so if you're using up a whole lot of your fibrinogen, turning it into fibrin, you're going to end up with low levels of fibrinogen. So if it's low, less than 1 gram per liter, that's also going to give you a +1. You just put all of that together. If it's less than 5, it's not suggestive of overt DIC. It's not a perfect rule out, but it's pretty clear that it's not, again, overt DIC. You should be monitoring these patients. There's still a possibility that it could become DIC, but you can kind of ease off and maybe look for other causes of the coagulation issues. If it's greater than 6, it's very consistent with DIC, and you should basically treat at that point that there's likely a DIC. And in both cases, you're going to repeat it. Again, if it's not suggestive, maybe you can get away with every other day as opposed to daily, but you're still going to want to watch these patients, because patients who do not have overt DIC could transition into having DIC, so you want to be careful. And if there's patients that have DIC, this can actually be a useful tool to measure how well they're doing. So as the DIC resolves, these numbers should get better, and your score should get better as well. So it's helpful both to say whether or not they have it and to monitor the patients once they have it. That's our DIC, and that's using a lot of coag. Again, we're going to move in more to before coag testing with a few of these scores going forward. All right, so the first one of those is the 4T score, which was developed by this guy, Andreas Grönecker. 4 cases of suspected heparin-induced thrombocytopenia. I haven't talked about that too much yet, but it's, again, kind of what it says on the TIM. So this is thrombocytopenia, so cases where patients have a very low platelet level, typically a sudden drop in platelets as a result of heparin. And that's because heparin can actually bind to platelets and activate them. And then they get activated, they get cleared from circulation, you get a very dangerous drop, both potential generation of thrombi as well as a dangerous drop in platelets, meaning that you can't clot properly. So this is a very dangerous condition, and this 4T score can help you figure out whether or not your patient's at risk for thrombosis or for heparin-induced thrombocytopenia. So the 4Ts are platelet fall, thrombocytopenia, the timing, thrombosis, and other causes, the T and other. It's kind of I have to smash that T in there, but it worked well enough. So again, working through this slowly. So for the platelet count, it's thrombocytopenia. So you have to show that the patient is thrombocytopenic. So it can be either a very sharp drop, they still have platelets, but it's a huge drop in your platelets, or if it fell less sharply, but they have less platelets overall. So if it's a very fast drop, you're gonna get a +2. If it's a slower drop, it's still very clear, and you end up with less platelets, that's a +1. So again, that's our thrombocytopenia. The timing is really the tricky part in this one. So these are caused by not just heparin and platelets, but specifically heparin platelet antibodies. So these are generated, these are an autoimmune condition, essentially, where these platelets are attacking this heparin platelet complex. And as a result, there's kind of a lead-in time of your body actually generating these antibodies. So if the patient has never had heparin before, it generally takes between 5 and 10 days for these antibodies to be generated. And so if it's been 5 to 10 days, that after heparin is started, you get a +2, because that's the typical time frame. The major exception to that is if they have had heparin previously, because much like any other kind of autoimmune sensitization, once you have the antibodies, they can react very quickly. So if the patient had recent heparin, they went off, then you put them back on and suddenly they have a platelet fall, that's also very typical of HIT. So if it's very quickly, within 1 day, recent prior heparin, that obviously gives you a +2. If you're still seeing it, it seems consistent, but it's not great with either one of those. If the timing is, you think it might be 5 to 10, but it's unclear, or if it's in a day, but it's been much longer since they've last had heparin, it's still suggestive, but it's not as specific, and so that gets you a +1. Next, it's not only thrombocytopenia, but you do have those thrombotic events as well. So if you have a new confirmed thrombosis or some acute systemic thrombosis, those are both going to be very consistent with HIT, so you get a +2 for those. If there seems to be thrombosis, but you're not sure, it's not confirmed, non-necrotizing skin lesions as well, or some episodes of recurrent thrombosis, that can give you a +1. So again, it's possible, but it's not as specific. The last one can be a little bit tricky, and it's just whether or not there's other causes of your thrombocytopenia. Right? So if there's other processes going on that you know cause thrombocytopenia, you don't get a point for that. But if you ruled out other causes, nothing else is going on, you get a +2. And if it's there's some, again, it's not confirmed, but there's a possibility, you get a +1. Again, like before, you add it all up together, and this helps you. This is very helpful for stratifying the risk of these patients. If the score is low, less than 3, there's a very low chance that your patient is actually suffering from HIT. At a 4 to 5, it's a moderate risk. Still more likely than not that it's not. But this is 14%. There's definitely, you're going to want to continue monitoring this patient and check and possibly stop heparin. And at greater than 5, you're really at high risk. And now it becomes more likely than not that your patient does have HIT. And so that can be very helpful. So once you have that, and especially if your patient is on the higher side, you again may want to take the patient off heparin, and you also want to confirm this diagnosis, and this is where we can do additional testing. So you start with your 4T score, and then you can move on to additional testing. 1 second here. I'm very sorry. Okay. So we can test for these antibodies. As I just mentioned, you're generating antibodies. We know how to test for antibodies. And there's 2 major tests we can use for HIT. And importantly, you want to use these when your 4T score is suggestive in the moderate or high risk category. If it's low risk, it's low risk, and your patients likely do not have HIT. But if they're in the higher side, this testing can be very helpful to confirm and make sure whether or not the patient has these. So there's 2 major types. One is looking just for those antibodies. So this is heparin. It binds again to this receptor on platelets called platelet factor 4. And you look for antibodies against those complexes. Oh, there we go. So we're just looking for antibodies that are binding this antigen. And so you mix the patient's serum with this heparin platelet factor 4 antibody complex and see whether or not you get antibodies binding. So it's just testing for the existence. This is less specific than the next text I'm going to mention, but it's far more widely available. And so especially in these patients where you're really concerned and you want to make sure that taking heparin off is the right choice, heparin antibody testing can be extremely helpful. So if they don't have the antibodies, there's a very low risk that they actually have HIT. But if they do have the antibodies, again, that substantially increases the risk for HIT. And so these can typically, again, more available, which means they probably can get back to you faster, and you can make faster decisions on your patient. Now, following up from this, if you really need to confirm a diagnosis, there is another assay called serotonin release assay. And this is where we're really actually very specifically looking at the platelets and whether or not they are being activated, because part of HIT is not just that the antibodies are present, but they're actually causing the platelets to activate, to cause thrombosis, and to, again, get cleared and cause the thrombocytosis. So here we actually will take patient platelets, and we'll expose them, or sorry, not patient platelets. We will take standard platelets and we'll expose them to patient serum and heparin. And if those antibodies are not only present, but are properly activating the platelets will activate, and platelets have serotonin in their granules. And so that will release serotonin, and we can measure the release of the serotonin. This is a highly specialized assay. Often it uses radioactivity measurements, and you do have to do this kind of biological testing on platelets. So it can take much longer, and it's not done by many labs. And so that's why this is useful for confirming a diagnosis, but typically, clinically, you're going to be looking for these antibody testing first, and that's going to be very helpful. And then you can follow up with what's called the SRA to confirm diagnosis. And this is the gold standard, but it may be slower, so you can use those antibody testing. Okay, our next tool, and the last major clinical tool, is the Wells score, creatively named after Dr. Phil Wells, who created it. And this is used to assess the risk of pulmonary embolism. And importantly, you really want to use this when you already have a clinical suspicion that there is a VTE present. You really don't want to apply this to all patients. It's not going to be as specific. But if you have a patient with chest pain, dyspnea, you do suspect a venous thromboembolism in this case, the Wells score can be extremely helpful. This one is a little more simple. It's kind of just a series of yes/no questions. First of all, is whether or not there's clinical signs or symptoms of a deep vein thrombosis. If this is true, it's a very good likelihood that you are going to be dealing with a PE, and so you get a +3. The next one is, all of these have some kind of wobbly criteria. This is this one for the Wells score, and is whether or not you think the PE is likely, or if your number one diagnosis. So this is really in your clinical estimation. If this patient really looks like they have a PE, it's a +3. If it's like, it could be, I just want to know, they have a VTE, but I'm not sure in this case, you wouldn't get that +3. So you have to consider it a good likelihood. Then it's their heart rate. If you're having a PE, your heart rate is generally going to be elevated, so that's going to give you a +1, 1.5. Next is, again, risk factors for DVT and VTE. So if they've been immobilized for multiple days, or if you have surgery in the last 4 weeks that could be causing thrombosis, you get a 1.5 for that as well. Secondly, if you've already had a PE or DVT, it's going to increase your risk for a further one, and so you get 1.5 as well. Hemoptysis, another 0.1, showing damage to your lungs. And lastly, if there's any malignancy with treatment, or things in palliative care, because again, this is just increasing your risk for thrombosis and increasing your risk that what you're looking at is a PE. So that's a +1. Again, same thing, you add it all together. If it's 0 to 1, it's really a low chance of PE. And so you can kind of move on. You really don't need to do imaging or further testing for PE. You're going to look at other causes for your chest pain and your dyspnea. If it's moderate or high, so greater than 2, it becomes much more likely. It's still not a slam dunk, and that's where we're going to move on with further testing, but it is going to substantially increase your risk over the low risk category. So this can be really helpful for stratifying patients. And now once you have this, then you can move on to your coag testing, and especially D-dimer testing. So we're going to talk a little bit more detail about D-dimer testing as we're coming in close. I mentioned D-dimer a few times. What the heck is D-dimer, right? So D-dimer is a breakdown product of fibrin. So you can see here, basically, as fibrinogen is being cleaved, it's going to form into these fibrin polymers, which is what's going to cause that clot matrix, right? Is these polymers of fibrin. Now, as that happens, fibrin gets solidified by factor 13. And what that does is create links between the fibrin molecules. Then, as the clot is being broken down, it generates these things called D-dimers. You also may have heard of a test called fibrin degradation products, or FDP. This is a very similar test. It's not the same, though. And it's looking at the similar thing, though, where you're looking at degradation of clots. D-dimer, though, is very, very specific, much more specific than FDP. for the breakdown of clots. So we recommend using D-dimer in general. So D-dimer is going to be specific for both the generation and breakdown of clots. Now, when I say specific, I mean specific for the generation and breakdown of clots, not necessarily specific for PE, which is another good reason to use the Wells score first. So you have an increased pretest probability that what you're looking at is PE. But once you have that, D-dimer is a very good way to really tell you whether or not clots are present. So it's used as an adjunct to Wells and not before, because it's not specific to PE. So if you test early, you may get a lot of false positives. You're going to want to use the Wells score first to really show whether or not you have a good pretest probability. But it's a good rule out. So a low Wells and a normal D-dimer is a very low chance of PE, and especially this means that you can potentially avoid imaging on your patients, which saves them time, saves them money, saves you time, and allows you to go and look at other causes of their problems if you're able to rule out PE. And this was shown very well in the study I have at the bottom, 2006 by the Christopher Group. They actually made it even simpler and made it dichotomous. So if the Wells score was 4 and below, it's low, 5 and above is high. You don't even have that moderate risk. And even there, a third of the patients in the study, which was many hundreds of patients, basically a third of them, which were in that low risk, 4 or less, with a negative D-dimer, had less than 1% risk of venous thromboembolism and PE. So this can really easily take out a whole chunk of your patients that you don't have to do further imaging on, and you can look for other causes. So these two in conjunction can be very helpful to rule out. And if it's positive, Wells score high, it doesn't mean you do have PE necessarily, but that's where your imaging can come in to be more specific at that point. But this allows you to stratify your patients quickly and relatively easily. All right. The last thing I'm going to talk about very briefly, especially since I mentioned it earlier, is ADAM-TS13. ADAM-TS13 has an extremely long name. I'm not going to tell you. Everyone calls it ADAM-TS13, and it's this protein, or it's a fragment of this, or this protein this is a fragment of the protein, and it's very important for von Willebrand factor, which is another coag factor. The really important thing you need to know is that it's important for thrombotic thrombocytopenic purpura. So this is a condition that you may suspect when the patient has petechiae, purpura, low platelets, and schistocytes. My guess is most clinicians on here know what to look for in TTP because it's extremely dangerous. Right? So without treatment, it's somewhere above 90% fatality rate for TTP. So this is a very, very scary condition. And the important thing with that is, since it's so scary, a lot of times we're going to start treatment empirically. You're not going to wait for an ADAM-TS13 test, even if you have it in-house potentially. And so you're going to start typically Plex and plasma exchange. And the important thing with ADAM-TS13 testing is that can really be helpful for confirming a diagnosis, but you have to get samples before the treatment is started. And again, this comes back to talking with your lab. So if you say, this is a snap judgment, you have to start treating this patient to make sure that they don't die. Maybe you don't have time to draw a sample, but the lab might have actually some samples from before. Once you get the patient on Plex, they're out of a danger zone, you can go back and see whether or not they have samples. And this can be extremely helpful, because if it comes back normal, you might not have TTP, and so you're going to have to look for other causes. And means you can maybe take the patient off of Plex and potentially save them the non-zero dangers of Plex. Certainly worse than TTP, but if you don't have to use it, that could be helpful. So measuring these levels can be very, very helpful. This is specialized testing, though, again, which is another reason you don't want to wait for the test to come back for starting treatment. But if you can get it, it can be very, very helpful. Okay, so that's all I have for you today. And just to bring it all together, my most important thing, I think, is that coag testing does not need to be confusing. It's really not that confusing. So just remember some simple things to make sure that your patients get the best results that they can. Number one with the bullet, fill up your blue tops all the way. That's going to be the best thing to make sure that we don't reject your samples and you don't get the wrong results. and avoid drawing those samples close to any IV line. And know the anticoagulants that your patients are on, and make sure to let us know as well, so that we can help to make sure that you get the best results that you can. And while you're talking with your lab, talking about the other interferences too, because that can be very helpful to know exactly what to avoid and what might be a problem. And also know that your clinical tools, and keep them in mind again, especially before coag testing, to really help stratify and make sure that you can make the best use of your coag results when they come back. And so know your 4T score and your Wills score. And with that, I just want to have some quick acknowledgments as we hit the 45-minute mark. First, Laboratories for hosting me and all this great Lab Week content in general. There's a whole lot this week, so I suggest checking it out. And my excellent teachers in coag. I am a chemist by training, so these two, especially Dr. Lindsay Bazidlo and Dr. Mariana Reyes-Gill, have really taught me a lot about coag testing. If you ever run into them at a conference, talk to them. They have excellent knowledge. And of course, Israel Gonzalez and Paul Riley specifically for hosting me for this talk. With that, I just have to say thank you, and can open for a few questions.
Sean, yeah, that was really great information. Really appreciate you presenting all that. And I think the information you shared, could be used as a way for the laboratory to go talk to clinicians about what they should know, as well as for the clinicians to go talk to the laboratory, as you said. So I really like this information you presented. What are some questions you receive most often from clinicians yourself when questions come to the lab about coag testing?
Yeah. Probably the biggest one, and the reason I included, right, is this going to mess with my patient's coag results? We get that all the time, right? Especially because it's such, it is a complicated pathway, and so people are often worried and about what's going to affect their coag results. And again, the answer, well, if it was my lab, I could tell you, but you're going to want to talk to your lab. But anticoagulants are the big ones, and those are the ones that obviously are going to cause the most problems. But those general ones, bilirubin and leukemia, you want to avoid if possible, or know about them. But that's probably the biggest one. Is really they are worried about things interfering with their assays. I think it's true of many clinicians. And so if you're in the lab, having that on hand and knowing so that you can give a quick answer can also be very helpful and appreciated.
Okay. And then what are some common misconceptions about D-dimer or HIT testing or DIC? One of those areas you talked about. What are some misperceptions or that clinicians may have about those test panels?
I can speak especially about D-dimer. I know it's really helpful for ruling out imaging, especially again with that low well score. But I know especially in our estimation, it's really not used that way. It's used, and then I don't know if people really pay attention to it, and it can be really, really helpful, especially when those patients have low well score, to help you avoid imaging. So that's a big misconception there. HIT and DIC testing, I think again it gets into the question of being kind of confusing and unsure about how to use that. So the scores that I mentioned, the 4T and the DIC diagnosis algorithm, can be super helpful to really clarifying what might be a very confusing picture. So I see that a lot, and that could be helpful to keep those in your back pocket.
It's basically just the scoring and when to order the testing.
Yeah, absolutely.
Okay. And then when you think about a new assay which might come on the market that the clinicians have heard about, but they might come to the lab and ask for help with implementation or understanding how the assay works. What's the process for that you've been part of?
Yeah, that's a great question. So usually a lot of times that shorter does go to the director, right? And they can usually have a really good conversation with you about how you want to use that test, what that's going to be useful for in your patients. And we want to bring in, usually for mostly what I've seen, right, we want to bring in as much as we can, because the more tests that we can give you, the better. And so that can be really helpful dialogue, especially because if you have a real clinical need, that's excellent information for us to know that we have to go and bring in a test. And then we can also, it can be very helpful to partner with you, with clinicians, for getting like samples, for knowing, the patients and the patient's condition. It can be very helpful for us if we do bring it in, to validate an assay and make sure that it's working properly. So that's usually the first step, and the best step is if you can get a hold of your director of COAG, especially in this case, obviously, they can help start that conversation and really help guide it forward as it goes. Because again, we want to give you the tests that are going to be useful to you. So that's, we try to be as helpful as we can.
Okay. And you mentioned Adam TS13, which seems to be something that's expanding in interest in the field. Do you see that test expanding in its use in the near future, or are there questions coming from doctors a lot lately, or how are you seeing that testing going?
Yeah, I do think awareness is growing, because I mean, we have treatments, we have protocols for TTP, but I think there's a lot of more awareness that Adam TS13 can be helpful for these patients, and knowing, I have to set aside samples, make sure it gets to the lab early, for this to help rule it out. And I know, again, it can help avoid plex in some cases, which both avoids potential side effects and can. It's an extremely expensive procedure, and so if you can avoid that, it can also be helpful. So I do. It's still specialized, but I do think that there's awareness growing around using it and using it to help make sure patients are being properly cared for.
Okay. Well, that was all the questions I had today. Appreciate you joining us and doing this customer education for us. We really appreciate it, John.
I was very, very happy to be invited. Thank you so much.